So this is the outline of my talk. Now, I'm going to be mostly speaking about the birth, the rise, and then the demise of the NHS in England. And here I just want to state at the beginning that although the letters, the logo, and the idea of the NHS still remains in the minds of many people living in England and the UK, in my mind, I think the NHS no longer exists. The NHS that we have today is not the same as the NHS that was established in 1948. So the words remain, but the essence of the NHS is no longer there. But before I talk about the NHS, I want to also make some generic points about health systems policy. And I'll also make some broad points about health systems challenges across the world that all countries face in this century. And then finally, end with a few lessons for the Malaysian health system reform process. Okay, so let me begin with the first general point, which is really to remind everyone that a health system performs multiple functions. Now, the most obvious function of a health system is to deliver personal and non-personal services, clinical services, public health services. And so we think about the health system as a mechanism by which we can convert inputs into a health system and transform them into processes and outputs that will then hopefully have an impact on the health of a population. But it's also important to remember that health systems have a cultural function. Think about the way in which a health system influences the profound human experience of birth, aging, and death. Traditional, cultural, and religious dimensions of health, illness, and mortality are really important if we want to deliver patient-centered care, but nearly always neglected. Health systems also have a social protection function. They help to mitigate the financial consequences of illness, injury, and disability, whether it's in terms of the cost of healthcare or the impact of lost earnings caused by illness and disease. Health systems also have a social function. They shape and they reflect social values and relations within a country. They determine the nature of the social contract between the state and its citizens. They help shape and reflect the relationship between the old and the young, between the rich and the poor, between people living in urban areas. I want to describe not just the rise and the fall of the NHS, but also the birth of the NHS. So with that, we have to think about, well, what existed before the NHS? So before there was an NHS, there was obviously a health system, but it was a very mixed health system. Financing was mixed. Financing was provided largely with out-of-pocket payments and heavily reliant on charitable donations. And you can see the poster here. It was quite common before the Second World War. Yeah, frequent appeals had to be made for charitable donations to keep hospitals going. There was some local municipality funding, primarily directed at providing care for the poorest in society and the most indigent. And there were also some mutual societies and sick clubs set up to try and provide some insurance function for people living in England. And these were voluntary on the whole, mutual societies and sick clubs. 1911, there was a rudimentary social health insurance system set up for working men, mainly paid for by the workers, only covered GP healthcare, only covered the workers themselves, not their families, and didn't provide any cover for hospital care. And in 1938, about half the adult working population had this form of insurance. As far as the provider landscape was concerned, this too was mixed. It was mostly private, a large amount of charitable provision, both at the primary care and the hospital level. There were some public hospitals run by local government, but again, they were very rudimentary. And at the primary level, there was actually quite a large reliance on charities like the Red Cross and St. John's. So in summary, the health system was very uneven. It was very variable with lots of unequal levels of access to healthcare and also quite a lot of unequal level of quality of healthcare. There was very little financial protection for people. So if you couldn't afford healthcare, you often went without if you couldn't access a charitable provision. And heavily reliant on private financing. So that was essentially what the health system looked like before the Second World War. So I want to jump now to 1948 and the birth of the NHS. And the first point I want to make about this is that in 1948, what was established was a huge and radical transformation of the health system that existed before the war. What was established in 1948 was, first of all, a system that was universal, made up of a single payer, funded from general taxation. There was a single pool of public finance that provided for a public workforce. As Dr. Subra mentioned earlier, it was free at the point of delivery. And within the act that established the NHS, it provided a very clear duty upon the state to provide healthcare for everyone in the country. So this is what it meant about the social contract. Legislated, duty on the state to provide healthcare for all. And the other important feature of the new NHS was that it was organized. Essentially, what happened was that the health system was demarketized. What we had now was an organized system. Planning was based according to need. There were area-based structures that were set up to organize and manage healthcare services in an integrated manner so that hospitals and primary care were managed as though there were different parts of a single system. And this is a newspaper clipping just showing how, another important feature of the NHS was the fact that all those hospitals that pre-existed were essentially nationalized. They were brought under state control, state management. 2,751 of the 3,000 hospitals that existed were now brought under state management and control. These had been previously run by charities and local government. How did this happen? How do we see this massive transformation from a disorganized, market-led system to one that was now organized and run as a public system, as a public service? So this was the result, first of all, of decades of social and political mobilization, going back decades. It was the result of mobilization, mostly led by working class movements, but also by others, wanting the state to play a much more interventionist role in protecting the rights and the dignity of everybody in that country. World War II had a huge impact as well. After World War II, there was also a sentiment of wanting to create a post-war settlement in which the state again would recognize the sacrifices that had been made by the entire country and wanting to play that, wanting to set up a welfare state and wanting to see the state take responsibility for the needs of everybody in the country. World War II also saw the government take control of hospitals during that emergency period of the war. They took control of hospitals, they took control of a national blood transfusion service, they set up a national public health laboratory service, and this demonstrated to them the ability to manage the health system as a public service and as a national public service. So there was also a confidence that had grown up in the public sector during the period of the war. And then finally, there was a Labour government that came to power rather unexpectedly, that was committed to these progressive social and political changes. And that was really key because there was actually a lot of opposition to the setting up of the NHS. And guess who was the biggest, where was the biggest source of opposition from? Doctors. And the opposition, overcoming that opposition from doctors, required really strong leadership from the government. And in particular, it required strong leadership from the Minister of Health. This is a picture of that minister, Nurin Bevan, who had a furious battle with the British Medical Association over the establishment of the NHS. He was described by doctors as a complete and uncontrolled dictator. He, on the other hand, accused the BMA of engaging in squalid political conspiracy and organizing sabotage of an act of parliament. And the fight was really about the terms and conditions under which doctors would be employed and managed and financed in the NHS. Eventually, a deal was brokered. So the NHS was established as a public system, as a universal national system, but GPs were allowed to continue to operate as self-employed businessmen effectively. And hospital consultants who would be employed by the state were allowed to continue to provide private practice alongside their salaried positions within NHS hospitals. When Bevan was asked how he managed to achieve this compromise with the doctors, he said, well, I essentially stuffed their mouths with gold. Now, I just want to make a couple of quick points about GPs. So they were allowed to be self-employed, independent contractors of the NHS, but they were essentially integrated into the NHS. And I really describe them as self-employed public providers. They worked under contract in the NHS. They were personally contracted. They were paid through a complex system of fees and allowances, but they were essentially treated as though they were part of the public workforce of the NHS. Another important part of the NHS is that the professions, particularly the doctors, but also the nurses and the midwives, they were bound by a very strong professional identity. And the royal colleges that exist in England and also exist here played a really important part in creating a professional identity that was national and that created a sense of professional pride. And that too helped to harness the role of the professionals in terms of providing service through the NHS. With NHS hospitals, these were publicly funded, they were publicly managed, and obviously they were publicly provided, but they were decentralized. They were governed through a number of regional health boards. An important part of the hospital sector is that they were also planned. So the building of the hospitals, the creation of new hospitals, all of that was paid for through a public budget, and it was provided through a public plan. So hospitals were built where there was a need for hospitals to be built. And it was all through public investment. Staff were on NHS contracts, and again, royal colleges played a really important role in ensuring that hospital doctors were professionalized and harnessed to delivering hospital care under the mission and the vision of the NHS. So I think for the next 40 years, from 1948, for 40 years beyond that, we saw the NHS continue to improve, make incremental improvements under this kind of broad umbrella of being publicly financed, publicly managed, and publicly provided. Now, it wasn't perfect, but anyone who has spent any time in England will realize how much the NHS is loved. As Dr. Subra said, it has been so cherished and so loved, so embedded into the identity of people living in Britain, that it was the centerpiece of the opening ceremony of the 2012 Olympics in London. One system for all, equitable, a source of pride for everybody, still deeply cherished. Wasn't perfect, but for people, both for the public and for doctors and nurses and other providers, everybody liked and loved working in the NHS. So how is it that the NHS no longer exists? Why, after this rise, has it suffered from a demise? And I would say that 1989 marks the turning point for the demise of the NHS. And it began with a set of new reforms introduced by the Thatcher government. And it was accompanied by the ascendancy of neoliberalism, not just in the UK, but this was the ascendancy of neoliberal policies globally, worldwide. And from this point onwards, the health system in England was subjected to a series of reforms aimed essentially at privatizing and marketizing the health system. Now, before I describe this process, I want to just briefly outline what I mean by neoliberalism. This is a well-recognized term that is described in the academic literature and well documented as a global phenomenon, associated also with the rapid globalization that has occurred in the last 4 decades. Now, I would especially recommend this book by David Harvey, a very readable account of the global ascendancy of neoliberalism and how it came to be the dominant public policy paradigm. Now, what do we mean by neoliberalism? What are the core tenets of neoliberalism? Fundamentally, at its heart, what we're talking about is an ideology that believes that free markets are the best way to organize society and that governments and the state should be kept small. Some of this belief is rested on the idea of public choice theory, which argues that state officials or public sector officials act like any other economic actors and pursue their own interests. Politicians will promote policies to maximize their chances of re-election. Bureaucrats will attempt to maximize their budgets because this may increase their salary, increase their status, or increase their opportunities for corruption. And as a result, public sector is wasteful and not concerned with efficiency or equity. On the other hand, the private sector has strong financial incentives to maximize the efficient use of resources in a way using incentives that don't exist in the public sector. So this is kind of fundamentally what is at the root of neoliberalism. And you can see this being expressed in quotes, and this is Milton Friedman, who is often seen as one of the gurus of neoliberalism. It's a little bit of a joke, but it kind of expresses the kind of fundamental mistrust of governments and this kind of fundamental belief that markets are always going to be more efficient, more effective than the state. Deeply embedded in neoliberalism is the assumption that humans are driven to maximize their own benefit, and also a belief that inequality and social hierarchies are not only natural, but they're also beneficial. This is what drives innovation, it's what drives enterprise, and this is therefore good for society. It's associated with a number of other ideas and beliefs. One is that economic growth will produce a rising tide that will lift all boats. So what's important is economic growth, not so much redistribution. And some will go so far as to say that redistribution can be harmful because it will reduce the incentive to be entrepreneurial or innovative. Embedded in this is also the belief that perpetual economic growth is possible, even though we live on a finite planet with hard biophysical boundaries. With these ideas, with these beliefs, with these assumptions, come a set of policies that are often described as being part of the neoliberal policy toolkit. Yeah. In order to allow free markets to thrive, we need to have deregulation. In order to have a small government, we need to lower taxes. In order to encourage the entrepreneurial spirit of humans, we want to see more marketization, more commodification across society. And initially, when neoliberalism was being promoted, it was primarily focused on the trade of commodities and goods. What we've seen more recently, particularly in the last 2 or 3 decades, has been the extension of the neoliberal policy paradigm into sectors that were traditionally understood as being within the realm of the public. So we see marketization in the health sector, in education. We even see growing marketization in policing, in prisons. So increasingly, we're seeing things that were assumed as being public role, public function. That too, over the last few decades, has been increasingly marketized and privatized. And a strong emphasis on technology and productivity. So policies that kind of form part of the neoliberal policy toolkit. The role of the state is seen primarily to protect property rights, to ensure law and order, and perhaps to provide a safety net for the poor. But the idea is keep the state small and allow markets to flourish. We even see neoliberalism and the ideas of neoliberalism being applied in the public sector in the form of new public management. So new public management saw bureaucracies in the public sector, policies designed to subject bureaucracies in the public sector to the discipline of competition and the discipline of the market. So we saw internal markets being created within the public sector. We saw the corporatization of public sector organizations, and we saw public sector bodies being forced or encouraged to compete with the private sector. And we saw gradually across the world a shift in the role of government from fund and deliver to steer and contract out. So the role of government was shrunk to kind of provide a governance function, and in order to steer public providers and private providers and govern the market, and that the market would do most of the heavy lifting in terms of the delivery of services and the allocation of resources. So that was the kind of slightly characterizing and generalizing what neoliberalism is. But that really is the kind of the beliefs, the assumptions, and the policy toolkit that has become dominant across the world. It's a set of policies that have been really heavily promoted across the world by the World Bank, by the IMF, but also increasingly delivered through bilateral and multilateral trade and investment agreements. Yeah. So this is what happened to the NHS. We began to see neoliberalism change and shift the NHS. It began in 1990 with the NHS and Community Care Act. We saw the beginning of this happen with GP fund holding and the creation of an internal market within the NHS. The beginning of hospital autonomization. So hospitals increasingly were encouraged to manage their own budgets, to be independent of the regional health boards that used to govern them. And we also began to see the deprofessionalization of management within the NHS. Instead of health professionals managing the NHS, we began to see an influx of people who had been trained with MBA qualifications, people from the business sector coming into the NHS and beginning to take on those functions and those roles. New user fees were implemented, an increase in co-payments, beginning to see an increase in private payment. We began to see the introduction of new language in the NHS, and particularly the language of choice. And the government started to talk about how important it was to have choice, that patients needed to have choice, GPs needed to have choice about where to refer their patients to. And this new language started, we stopped calling patients patients, we started calling them customers and clients. And of course, none of this was based on what the public wanted. Survey after survey after survey, when you ask people what do they want from an NHS, choice is never what they say they want. What they always talk about is that they want a service that is local, that is near them, and they want a service that they can trust. Those are the two things that they most often talk about, not choice. Then we began to see the outsourcing of non-clinical services. So hospitals started to outsource cleaning, hospitals started to outsource the laundry, food. And all of this was introduced by the Thatcher government. When the Conservative government was replaced by a Labour government, instead of seeing a reversal of these policies, we actually saw a continuation of the neoliberal policy paradigm. And the Labour government, which came in power in 1997, continued with the development of a purchaser-provider split. Primary care trusts were set up, and they were established to purchase healthcare from hospitals, from GPs. Hospitals were given greater autonomy and responsibility. We saw the introduction of tariff-based payment systems, greater local pay bargaining, and then in addition to the outsourcing of non-clinical services, we began to see the outsourcing of clinical services as well. So that we saw the establishment of independent sector treatment centers, and we began to see companies like Virgin, Richard Branson's company, starting to provide healthcare under contract from the NHS. 2004, a new GP contract was set up, which began to unbundle primary care services. So whereas previously all primary care was bundled under a single contract, we began to see the unbundling of primary care services, which enabled, again, greater opportunity for outsourcing clinical care to different companies. We saw new contract modalities. So instead of GPs being hired directly by the NHS, GPs from 2004 onwards could only be hired through a contract with a company. Yeah. And these new contract modalities were the new contract modalities that enable private companies like Virgin to be able to establish contracts with the NHS. And then we also saw the beginning of private finance initiatives. So this was an initiative aimed at getting private investment in to build new hospitals. So this was about the private financing of capital infrastructure. And essentially what happened is that under PFI, we saw a consortia of builders, banks, and service providers come together to build hospitals. In exchange for the private investment that came in, the government gave over land to these consortia, and that land was then leased back to the NHS, and the buildings that were built were then leased back to the NHS. So the NHS then paid to be able to essentially rent those buildings that had been built by PFI. This was a disaster. The contracts were badly set up. They were more expensive. The cost of building these hospitals were more expensive than they would have been had the government borrowed the money and built them themselves. And many of the hospitals were poor quality. In 2012, we saw a new act come in, and this was the legislation that also then removed the duty of the state to secure and provide comprehensive healthcare for everyone. So what was established in 1948, the duty of the state, that was then weakened and watered down. And the duty of the state became one of acting with a view to securing comprehensive care. It's a subtle change in wording, but very profound in terms of what the public and what citizens can then demand of the government. Strategic health authorities were abolished, and new structures were set up, and the Department of Health was shrunk, and new bodies were set up. The NHS England was a new body with responsibility for the clinical commissioning groups that were set up to commission healthcare. There was a new economic regulator whose function was to set NHS prices and rules for the market, and a care quality commission, a new body to assess and supervise provider quality. NHS or public sector bodies were no longer the preferred providers. So the commissioners, the people that were purchasing healthcare, previously they were expected to treat the public sector as a preferred provider. The 2012 Act removed that requirement and essentially said, now you need to treat public and private, NHS, non-NHS provider as though they were equal competitors within a market system. They had to compete for the contracts. NHS hospitals were given further autonomy and responsibility, and for the first time, an NHS hospital was allowed to fail. Until now, if an NHS hospital ran into trouble, the government would bail it out. Now we began to see A&E departments shutting down, and failing hospitals, if they were struggling to balance their books, they had to cut. And we also saw the end of nationally determined pay and pensions. Now, during this time, health expenditure as a percentage of GDP was actually rising. It was going up. And I want to make this point because the mere fact that health expenditure rises, the mere fact that a bigger proportion of GDP is spent on healthcare does not necessarily mean that the health system itself is going to function better. Now, with the marketization, what we've seen is a large amount of that increased expenditure consumed by administrative and transactional costs. 2013 to 14, it was estimated that there were 52,800 separate contracts between the NHS and the private sector. 25,000 staff had to be employed to write, administer, and monitor those contracts. Never mind all the administration required to manage what was left of the public sector itself. And I guess the other point is that the rise in the proportion of GDP spent on healthcare expenditure, not only did some of that get spent on these increase in administrative costs, but with the private providers, we also had to make room for profits. So again, some of that expenditure had to then be funneled into profits. So that, in brief, I'm kind of trying to show this kind of progressive change of the health system in England, away from that single, comprehensive, integrated, coherent system to a very mixed system. One where there was a mix of markets and now a mix of public and private providers. And instead of having this coordinated and planned system, we have a system where there is a mix of coordination and planning. And obviously, the requirement to bring in the private sector required an element of marketization. And that also required an element of segmentation and fragmentation. So this is a diagram. Just thought it might be useful to try and summarize the changes using this diagrammatic representation. So this is the NHS when I was a junior doctor. You can see that this is the health system. Most of the health system, this box represents the health system, and most of it in dark blue consists of the NHS, publicly funded, public budgets, public provision, hierarchically and geographically organized, integrated, planned, professionally led. There was always some private finance. There was always some out-of-pocket payments and private insurance. People know about Harley Street in London. Some people would pay for private care. And there was always private provision. And of course, that includes the pharmaceutical companies. You know, drugs and equipment were provided by private providers. So it's not like the health system was entirely public. But what we then saw was change, beginning with these new public management reforms, the creation of an internal market, purchaser-provider split, outsourcing, consumerization. With that outsourcing, we saw a bigger portion of the provider system become private. And over time, more marketization, more competition, and more active privatization. Private provision increased. And with the rise of private investment, we begin to see that the amount of private finance in the public-private mix also changes and shifts. Now what we have is not just the beginning of a more marketized system with private providers and private financing, but new legislation has also provided opportunities now for the private sector to be involved in commissioning, in managing the budgets. So the new bodies that have been established just recently allow for not that there would be a public body to manage the budgets, but that there would be public-private partnerships established to manage the budgets. And so this is, you know, the beginning also of what some people feel will be the emergence of health maintenance organizations, HMOs that would be, which would be managing both budgets and providers through a mixed public-private system. So this is no longer the NHS. So I talk about RIP, NHS, rest in peace. Now, I've talked a lot about structures and systems and finance, but perhaps the biggest thing that has changed is the culture within the NHS. What has changed is cultures and values that were embedded in a public system, national solidarity, cooperation, and trust. What we now have throughout the system, whether you're working in a public organization or a private organization, is a mentality where you're constantly thinking either of generating a profit or generating a surplus. And you're thinking about competing with others, not cooperating with others. And for people in the public sector, instead of thinking about how do I improve the quality of care, what you're responding to increasingly is performance measurement measures, top-down performance management that is often counterproductive, that often breeds inefficiency, because these are managers that are thinking about indicators, selective indicators, that may not have any true bearing to quality of care. And this has deprofessionalized the health system, but it's also bred increasing amounts of resentment, demotivation, demoralization, and also mistrust within the NHS. Before going on to the white paper in Malaysia, I just want to say that beyond what's happened to the NHS, England, as with other countries, also face a whole bunch of other challenges. There's the ecological crisis that I think all of us are aware of. We all live with a cognitive dissonance about the state of the ecological ecosystems upon which we depend. England, as with Malaysia, is facing an aging population or an already aged population with multi-morbidity. and a rise in anthropogenic disease, burden of non-communicable diseases, and we don't have the right policies in place, the right structures and systems to manage the aged population. Rising levels of social division and inequality. Artificial intelligence is emerging, and it's being expanded and introduced into the health system, not necessarily with much in the way of thinking about what impact this will have on health workers and human resources. And we have technology-driven medical inflation. These are very powerful companies that are really promoting all kinds of new technological innovations. And many countries now lack the capacity and the ability to manage those inflationary cost pressures on the health system. So, what are the lessons for Malaysia from this, I think, sad story of the NHS and those kind of big external pressures facing England and other countries? So I'm very reluctant to transfer lessons from one country to another. Every health system is unique, and the impact of any health policy or reform agenda will depend on a whole range of factors and contingencies that are unique to that particular country or setting. The second thing is that policies are only as good as the people and the systems through which they are being implemented. So you can implement one policy in one country, doesn't necessarily mean it will have the same effect in another country. However, I think there are a couple of lessons to be drawn that I think are relevant to the Malaysian system and to the aspirations that are embedded within the white paper. And the white paper really is aspirational. The first is to say that healthcare reform is fundamentally a socio-political process. And if you want to achieve the reforms and the ambitions of the white paper, there has to be clear government leadership around a clear vision. You know, we fund, organize, and manage a health system according to the values that we prioritize. The technocratic debates that we have are often obscuring the more fundamental underlying competition for benefits amongst different interest groups and segments of society. And I think it's only government, ideally working with cross-party consensus, which will have the power and the mandate to reshape and redesign the health system so that it is better able to serve the needs of all people in a manner that is equitable. And the truth is that all examples of successful healthcare reform demonstrate the central importance of government leadership, government vision, and coherence within government. So that's the first message. And we saw that with the birth of the NHS, and we've seen it with the demise of the NHS, because the demise of the NHS was also driven not by the people, not by the public, but driven by government policy. The second is reforming the public-private dichotomy is key in Malaysia, and this means having to face fundamental choices between the use of markets and the use of networks and organized hierarchies. And here, I just want to maybe mention that we have to kind of really challenge the last 4 decades of assumptions, beliefs, and narratives that have talked up the virtues of the market, talked up about, talked up the view that markets through competition can increase efficiency, the view that regulation can be used to fix market failures, the view that profit motivation drives innovation, the view that charities in the public sector can fill market gaps, the view that private investment can increase total spending, the view that hierarchies and the public sector are inherently inefficient, the view that there are no incentives to be efficient in the public sector, and this public choice theory, which views that anyone working in the public sector is going to work in a way to further his or her own personal interest. These are the views and assumptions that have become so prevalent. And we need to counter that with the fact that market failures are extremely strong in the healthcare sector for a whole variety of reasons. That competition and markets undermine cooperation and continuity of care, that the profit motivation is overrated, and that there is huge amount of innovation that goes on in the public sector, that a public service for the poor almost always becomes a poor service, that private investment is often expensive, that is extractive and very often destructive, that the public sector can come in many different forms. It doesn't have to be rigid, inefficient and bureaucratic. That in fact, if we saw with COVID, the public sector can respond quickly, the public sector can plan, the public sector can build. All the 30 years of health improvement that occurred in Malaysia after independence was public sector led through a planned process. That non-financial incentives do work. And also there is something called a public service ethos. And that it is possible to hold public sector providers accountable, and that we can make government efficient and effective. The final thing, the big picture with the white paper. No health system in any country can afford to be a sickness system. We see this in England, we see this everywhere. Health system is geared towards treating diseases and illnesses. We have to be thinking about prevention. We have to be thinking about upstream interventions to prevent people from being sick. And although this is a multi-sectoral endeavor, it should and it can also lie at the heart of the mission of the healthcare sector. So hospitals can be preventative, GPs can be preventative, even ambulance drivers can think about how they can contribute to the preventative agenda. And ultimately, to kind of cope with the challenges of the future, the kind of challenges that are facing all countries, it's really important to strengthen primary healthcare and the public health system. So that's where I'm going to end. Thank you for... I think this white paper presents an opportunity. It went through Parliament, it received support on both sides of the aisle. I think there are issues with the Malaysian health system that need to be tackled. I don't think it's going to be easy. There are all kinds of obstacles to the kind of transformation that I think is needed. But ultimately, the transformation that is needed depends on what we want, what kind of a health system we want. Do we prioritize equity over efficiency? Do we prioritize prevention over curative care? How do we create a system where all the different competing interests can ensure that the system is fair for all, for the public, but also for the providers? So maybe it's because I'm not here as a Malaysian that I am hopeful and optimistic about the white paper, but I do think there's a real opportunity. And yeah, I hope learning from the demise of the NHS provides some kind of useful information or input as to how important it is to grasp this opportunity to really protect and promote the health system here in Malaysia. And especially given the amazing reputation of the Malaysian health system. It's still well regarded internationally. So it'd be good to be able to preserve that reputation.